The management of malignant bowel obstruction. Welcome to today's episode of the Everything Surgery podcast, where we look at malignant bowel obstruction. Malignant bowel obstruction is one of the most challenging and distressing complications faced by individuals with advanced abdominal and pelvic cancers. It arises when a tumor physically blocks the passage of the small or large intestine. This complication is most frequently seen in cases of ovarian, colorectal, gastric, and pancreatic cancers. When malignant bowel obstruction occurs, it often signals a major shift in the patient's journey, typically indicating a poor prognosis, with median survival times usually ranging between 1 and 3 months. To understand what is happening, it is important to recognize that malignant bowel obstruction is not just a simple blockage. Beyond a mechanical obstruction caused by the tumor, there is often a functional element. The cancer may invade the tissues of the mesentery or the bowel wall, impairing the normal muscular contractions, peristalsis, that move contents through the intestines. Inflammation and swelling can further worsen the obstruction. Because of this complexity, treatment is not straightforward. The focus shifts away from cure and towards aggressive management of symptoms. The key goals are to relieve nausea, vomiting, and pain, and, if possible, to allow the patient to return home and eat comfortably. In this episode, we will walk through a detailed and practical approach to managing malignant bowel obstruction, designed to guide clinicians, patients, and families through this difficult stage. Step 1. Initial assessment and triage. Diagnosis. The diagnosis of malignant bowel obstruction is based on the combination of clinical symptoms, such as nausea, vomiting, complete constipation, cramping abdominal pain, and noticeable swelling, and imaging, with computed tomography scanning being the gold standard. This imaging not only confirms the obstruction but also clarifies its location, whether there are multiple sites, and whether there is widespread spread of cancer within the abdomen. Patient selection. The next step is to determine whether a surgical approach or a purely medical, palliative approach is most appropriate. Surgical candidates. These are typically individuals with a single, easily accessible site of obstruction, who are in relatively good health otherwise and have a reasonable life expectancy. Palliative candidates. This group includes those with extensive spread of cancer, multiple sites of obstruction, poor functional status, significant fluid buildup in the abdomen, or a history of unsuccessful surgeries. Step 2. Conservative medical management. The foundation of palliative care for those who are not candidates for surgery. The emphasis shifts to controlling symptoms and, if possible, avoiding long-term use of a nasogastric tube. This palliative approach is centered on medical management, bowel rest and hydration, nilperos, NPO. Patients are advised to stop eating solid foods, which helps to decrease the production of digestive secretions and reduce the workload on the intestines. Intravenous fluids. Fluids are given to prevent dehydration, but their use must be carefully balanced to avoid causing further swelling around the obstruction. Subcutaneous fluids. Hypodermolysis. This method offers a practical alternative in hospice settings for providing mild hydration. Pharmacological management. The triple therapy approach. Antisecretory agents. These medications reduce digestive fluid production, easing vomiting and abdominal swelling. Common choices include octreotide, a somatostatin analog that suppresses secretions and can often break the cycle of functional obstruction, and hyoscine butylbromide, which also relieves cramping pain. Antiemetics. These drugs help control nausea by blocking vomiting pathways. Metoclopramide may be used if there is only partial blockage, but it should be avoided in complete mechanical obstruction. Haloperidol works at the central nervous system level and is especially useful for chemically driven nausea, while cyclizine is effective for nausea related to motion. Analgesics. Pain may present as cramping, colicky, or as persistent visceral discomfort. Cramping pain is often relieved with antispasmodic agents like hyoscine butylbromide. Continuous pain typically requires opioids such as morphine or hydromorphone, but monitoring is essential as these can worsen constipation. Corticosteroids. For inflammation and edema. Role. Corticosteroids such as dexamethasone are used as an adjunct to reduce tumor-related inflammation and swelling near the obstruction, sometimes leading to temporary improvement or even resolution in a small proportion of cases. Outcome. They are typically prescribed as a short trial and, if effective, can open a window for other therapies or improved comfort. Step 3. Decompression procedures. When medical therapy does not adequately relieve vomiting, decompression of the digestive tract becomes necessary. Nasogastric tube. Use. This tube provides immediate decompression and relief from vomiting, which can be critical in the acute setting. Limitation. However, prolonged use is uncomfortable and socially isolating, so the aim is to transition to more comfortable options when possible. Venting percutaneous endoscopic gastrostomy. Concept. This is a tube placed directly into the stomach, allowing content to drain freely, either continuously or intermittently, providing ongoing relief from vomiting. Indication. This is especially suitable for those who do not respond to medical management. Advantages. It allows patients to remove the nasogastric tube, and, in many cases, to sip small amounts of liquid for comfort, greatly enhancing quality of life. Dual lumen tubes. Some devices offer a separate port for drainage and feeding, but this can be complex and is less commonly used in malignant bowel obstruction. Step 4. Surgical and interventional procedures. Surgical resection or bypass. Indication. This is reserved for carefully selected patients with a single site of blockage and limited spread of cancer, who are otherwise in good condition. Procedures. Surgery may involve removing the obstructed segment or creating a bypass, such as a gastrojejunostomy or colostomy. Outcome. Although this can provide lasting relief, it is associated with significant risk of complications and death, given the frailty of these patients. Self-expanding metal stents. Concept. A wire mesh tube is placed endoscopically or radiologically to hold open the narrowed part of the bowel. Indication. These are best suited for single, short blockages, especially in the lower colon or near the stomach outlet. Advantages. This is a minimally invasive approach that offers rapid relief and a shorter hospital stay. Disadvantages. There is a risk of perforation, migration of the stent, tumor growing into the stent leading to recurrence of symptoms, and pain caused by the stent itself. Step 5. Total parenteral nutrition. Role. The use of intravenous nutrition is controversial in those nearing the end of life. Indication. It is generally reserved for patients with very slow-growing cancers, such as ovarian or neuroendocrine tumors, who have good function and a life expectancy greater than 2 to 3 months, where the obstruction is the main life-limiting problem. Ethical consideration. In most hospice patients, the risks, including infection, liver dysfunction, and fluid overload, outweigh the benefits. The priority remains comfort, which may include allowing natural starvation with good mouth care, rather than pursuing aggressive nutritional support. Summary of clinical approach. To recap, the management of malignant bowel obstruction follows a logical sequence. First, confirm the diagnosis with imaging and rule out other reversible causes. Next, insert a nasogastric tube for immediate symptom relief. Begin medical therapy, using octreotide, corticosteroids, antiemetics, and analgesics. Then, determine the appropriate pathway. For those who may benefit from surgery or a stent, proceed accordingly. For those who are best managed palliatively, if medical therapy fails, transition to a venting gastrostomy tube. Maintain antisecretory medications, and focus on pain and anxiety control at home or in hospice. Conclusion. Malignant bowel obstruction marks a terminal stage for many patients. The aim of management is not necessarily to extend life at any cost, but to ease suffering, to free the patient from relentless nausea and vomiting, to control pain, and to help them return home or to hospice with dignity. For those in palliative care, the combination of a venting gastrostomy and antisecretory medication stands out as the most effective approach to improving quality of life. Thank you for joining us on this episode of the Everything Surgery podcast, where we take a closer look at the extraordinary journeys and challenges in surgical care. If you found this discussion helpful, please like, share, and subscribe. Until next time, stay curious and compassionate.